Però credo di avere ancora un po' di minuti.
C'è anche il dottor Padolecchia che lo sta seguendo.
No, è chiuso anche il video.
Hi, everyone. Thanks for joining. Looks like there's two maxims here. We're like not mutating or anything. I'm away for this week. So Eitan's running. He's the other maxim. So there's two of us. But really, I want to thank everyone for coming. And we have we're recording this, so if someone hasn't joined, they can let them know to look at it. It's going to be something different today. Walid, I see Walid looking on. We have Walid's going to present something a little bit different than CSF hypotension, not hypertension. Now we're on the other end of the spectrum. We have Walid's presentation. Should lead some interesting discussion. And there's a case by Luca, similar in the similar lines. So that case Suki, I think, is another case after that. So we're gonna wait maybe a few minutes, right, Eitan? And we'll get started afterwards. Eitan, thank you so much. Thanks for everybody for joining. There's still some people coming in, so let's wait a few maybe.
Great. And Max, can I share my screen?
Yes. Please do. Are you able to, if you're not able to share the screen?
It just says that the host disabled participant screen sharing.
Try that now.
There we go.
Excellent. Okay. Let's wait another 2-3 minutes and then we start.
Great.
All right. Eitan, can you hear okay?
Here is the other Max.
Excellent.
How are you? Hi,
Good.
Walid.
Hey, how's it going?
Thanks for presenting this.
Oh, thanks for having me. I'm looking forward to it.
はい。はい。
Hello.
While we're waiting, just no real announcements, but certainly we want to encourage everyone to submit cases. Not, we're singing to the choir here, but if you know anyone who has interesting cases who wants to present in our format, which is basically not so much of a format, you just present and then there's questions, let them know. I think it's really makes for a great discussion when anybody can participate. Okay. Another minute, maybe 8:05 we start.
Sounds good.
Anything else? Anyone else has any questions, announcements? Okay.
Max, how to make somebody share the screen?
It's advanced sharing options. All participants can share now, and only one participant can share at a time. And the host has control of that. So it's that little.
Yeah, I see.
Share. So I think anybody can. So Walid should be able to share now.
Yeah, you guys can see my screen, right?
Right now.
I do.
Yeah.
All right.
Okay.
Should I get started?
Yeah, let's go ahead. Okay, yes, please. Thank you, Walid. Thanks so much for coming.
Yeah, so I'm going to talk about something a little different, paraspinal vein embolization. It's really radicular vein embolization for treatment of CSF venous fistulas. Max had asked me to give kind of just an overview of the disease beforehand. So I know many of you are familiar with this disease, but many of you might not be. So I'm just going to give a brief overview of CSF hypotension before going on to the technique in our results. So, there's two types of intracranial hypotension. We have the primary or spontaneous intracranial hypotension, and then we have a secondary type, which is usually iatrogenic, secondary to lumbar puncture, surgical procedures, epidurals, etc. Now, spontaneous intracranial hypotension, which is what I'm going to focus on for the remainder of this talk, it primarily affects middle-aged patients, 30 to 50 years old, more common in women, probably 2-to-1 ratio. And it's not rare, but population-based epidemiologic studies there aren't that many of them available. But there are some estimates that say that the prevalence of this disease is similar to that of aneurysmal subarachnoid hemorrhage. So I don't think it's really an orphan disease in the strict sense of the term. Now, the etiology of this disease, it's due to a leakage through a dural defect, and it can occur at multiple rates. So you can have fast leaks, slow leaks, or delayed leaks. And a variety of causes are reported. So either, weakness of dura, associated with meningeal diverticula and connective tissue disorders, or dural tear associated with spinal lesions such as osteophytes or disc herniations. And then lastly, spontaneous CSF venous fistulae. The clinical presentation of this disease is, typically most patients have orthostatic headache, and basically it occurs within 15 minutes of standing upright, resolves within 15 to 30 minutes of lying down. And other presentations include chronic daily non-postural headaches, posterior neck pain or stiffness, nausea, vomiting, gait disturbances, memory issues. This is actually huge. I mean, I've seen numerous patients now that have, brain fog, high functioning individuals who can't function because their memory is just not there. And rarely this can progress to stupor, coma, and other, severe neurological syndromes due to brainstem compression. They could also get superficial siderosis with the whole host of diseases that can cause. They can get sensory neural hearing loss and vestibular symptoms. And that's actually due to imbalances between the CSF and the perilymph and endolymph in the inner ear. I could talk for an hour on that. The diagnostic criteria for SIH, criterion A, demonstration of a CSF leak, or MRI changes of spontaneous intracranial hypotension with either meningeal diverticula, low opening pressure, or improvement of symptoms after epidural blood patching, or all three of these from criterion B, or if you have two of these in orthostatic headaches. So, it's again, there's a whole host of symptoms that these patients can present with. So the diagnostic criterion cover a wide, spectrum of symptoms. And I just want to point out that a lot of the work that's been done in CSF hypotension, has come out of Cedars-Sinai, and also Duke, and over the course of the past 5 to 10 years, Mayo as well. But the Cedars-Sinai group has done a lot of the pioneering work in establishing diagnostic criteria and everything. So what are the imaging findings? What are we seeing on imaging in these patients? So on MRI, sagittal T1 MRI, we see characteristic findings like effacement of the suprasellar cistern or draping of the optic chiasm over the pituitary gland, effacement of the prepontine cistern. So basically, you should have about 5 millimeters of CSF between the belly of the pons and the posterior margin of the clivus. Tonsillar herniation is another common finding, or tonsillar ectopia. And then another thing is, like, these are the mammillary bodies right here. So decreased mammallopontine distance. Usually you should have like 5 millimeters or so between the mammillary bodies and the top of the pons. On axial MRI, we can see subdural hygromas or fluid collections or hematomas. That's basically due to the brain sagging, the decreased pressure, and then basically you have fluid that fills the subdural space. And then packing meningeal enhancement, which is basically seen in over 90% of patients with spontaneous intracranial hypotension. Other findings, pituitary engorgement. Another very common finding is engorgement of veins. Essentially, we can see like engorgement of the dural venous sinuses, but also look here, this median pontomesencephalic vein is engorged, and you can see even the anterior spinal vein is engorged because you have low CSF pressure. So then the veins dilate, to accommodate for that because of the whole, Monro-Kelly hypothesis. And then you have ventricular collapse. And then on spine MRI, we can see engorgement of the epidural venous plexus. That gets into the whole thing about veins getting engorged in this disease. And then in patients with fast leaks due to ventral dural tears, which is not the focus of this talk, you can see ventral epidural fluid collections, but I'll get to why this is important for what we're discussing today momentarily. So what's our diagnostic algorithm for patients with a high clinical suspicion of spontaneous intracranial hypotension? We get a brain and spine MRI. And if there is an extradural fluid collection, kind of like that thing that I showed you earlier, if we see the extradural fluid collection, then we do a hyperdynamic CT myelogram with the patient in prone position, because usually these leaks are ventral epidural. Like here, it's probably because of this osteophyte right here, right? Now, if there's a leak there, then we do a targeted therapeutic intervention. Usually this involves surgery. But if there's no leak, if we can't find it despite this workup, then we do multi-level epidural blood patches and then reevaluate. Now, if you don't see a extradural spinal fluid collection, then we say that this is a slow leak, okay? So that it's leaking either into, the fat surrounding a nerve root sleeve, or could be leaking into a vein. So this is an example of a spine MRI without an extradural fluid collection. You can see the band of the dura right here and how there's fluid between the between the spine and the dura. Here we see no such band. There's no extradural fluid collection. Now, for these patients, we used to do a conventional CT myelogram, but we found that the diagnostic yield of a conventional CT myelogram was so low that we've just switched to doing lateral decubitus digital subtraction myelography. If we find a leak, then we do the targeted therapeutic intervention. But if we don't, then we reevaluate and consider repeat DSM. I'd say the diagnostic yield of the repeat DSM is about 20% in patients with high clinical suspicion. So now I'll get to the focus of this talk, CSF venous fistulas. This is a picture that I took from an article that Richard Farb at Toronto Western had published. But basically, you have a direct connection between the intrathecal CSF and a paravertebral vein. So here, you see the nerve root sleeve. This is the CSF, around the spinal cord. You have CSF in the nerve root sleeve. And you have this direct connection between the CSF and the nerve root sleeve and the paravertebral vein or radicular vein. And it was actually, who knows when it was really first described, but I think the first real description of the CSF venous fistula was probably in 2014. And, we're not really sure what the etiology of this. Is it developmental due to, like an exuberant arachnoid granulations? Because as you may know, there are arachnoid granulations in the nerve root sleeves in the thoracic, cervical, lumbar spine that play a role in CSF resorption, particularly in neonates in early life. We think these are likely under-recognized because it's so hard to diagnose them if you don't do digital subtraction myelography. And generally, these things have been treated surgically, which basically involves surgical ligation of the nerve vascular complex. Now, when was this really described? Now, this is actually very interesting. This is an article, from Journal of Neurosurgery in the 1970s. They were doing pantopaque myelography in a couple of patients with lipomas or masses of the spine, and they noticed that pantopaque ended up in like the veins in the thoracic and cervical spine in these patients, and they said spinal fluid venous fistulas. Now, at this time, it was not recognized as a cause of CSF hypotension, but it is interesting to see, how these people were very astute and picked up this peculiar abnormality. I just think it's always interesting to go back to the old literature. Now, again, like I said, the pathophysiology of the CSF venous fistula is very unclear. One of our surgeons, he's operated on 30, 40, 50 of these, and he's noticed that, he sees like this nerve root that's kind of enmeshed within this, very exuberant venous plexus. And, he suspects that there might be a remnant of like an arachnoid diverticulum in the nerve root sleeve, which could be contributing to the presence of these CSF venous fistulas. Again, we really don't know. If anybody does know, though, I encourage you to speak up. But it's just a lot of hypotheses right now. So this is the entity that we're treating: CSF venous fistulas in patients with spontaneous intracranial hypotension. So the next question is how do we diagnose these things, right? So there's three main techniques that have been used to diagnose these, right? So one of them is CT myelography. Now here's just 7 cases of CSF venous fistulas that we picked up on CT myelography. Now on CT myelography, what you want to look for is something called the hyperdense paraspinal vein sign. So here's an example where you see there's contrast in the nerve root diverticulum, and these diverticula go out pretty far. They don't stay just within the foramen, they extend out the foramen. But you can see here, this paraspinal vein is just it's a little dense. It's a little more dense than this vein right here. Here's another example of a vein that's getting opacified with contrast. And this is a nice one, right T4, T5, right T3, T4, right T9, T10. just subtle increased contrast enhancement of the vein. Now, at Duke and some other centers, they've mastered lateral decubitus CT myelography, where they do dynamic CT myelography, and they basically puncture and inject contrast in the scanner, and can get really excellent and dynamic images. We're still working on the CT myelography technique here at Mayo. We rely primarily on digital subtraction myelography, and I'll get to that in a second. MR myelography is another technique that's commonly described in the literature. Basically, you put small amount of gadolinium, like 0.1 cc's in 20 cc's of saline, and inject that into the CSF space, and then do MRIs right after, and then also in delayed fashion. You can see here how on this T1 weighted MRI, we have bright CSF because there's GAD in the CSF, and we have this bright paraspinal vein right here. And here's another such example where you have bright, CSF, this big nerve root sleeve diverticulum, and this bright paraspinal vein right here. We did this for years, like 10 years at Mayo. And the diagnostic yield of this study was probably like 5 to 10%. So sometimes you get these beautiful pictures, and that's what everyone sees in the papers. But in reality, it's not that good, at least in our experience here. Now, digital subtraction myelography, I think this is what you want to do. If you want to build a practice on CSF hypotension, you want to find CSF venous fistulas, and you want to treat these things, you need to be doing digital subtraction myelography. So I learned this from Richard Farg in Toronto when I did my fellowship there. I think he said he learned it from the Cedars-Sinai group. Cedars-Sinai group, very big proponents of digital subtraction myelography. So basically, this is the article right here that you could look up and get all of the secrets and tips. And if you have any questions, you can reach out to me or DK Kim on how we're doing it. But basically, we have the patient on the table. They're lying on their side. They're tilted. We tilt the table a little bit as well. We puncture, L3, L4, L3, and then we inject contrast, under angiography settings. So basically 1 frame per second, and watch the contrast as it flows in each neural foramen. Okay. So this is an example of a digital subtraction myelogram of showing a CSF venous fistula in a patient that I actually treated yesterday. So here, this is at T12. This is unsubtracted. I'll show you the subtracted in a second. The contrast is coming up. As the contrast is coming up, look right here. Do you see the flickering of this vein right here? And this vein right here, you can see the contrast actually going in the radicular vein, and then the paraspinal vein, and then flowing up into the azygous vein right here. Now I'll show you the subtracted version. So here's the subtracted version, and you can see here how the contrast is going in the radicular vein, then opacifying the paraspinal vein and the azygous vein right here. So this is the kind of stuff that you can see with digital subtraction myelography. And this is to convince you that this is definitely going in a vein. Now, there's a big learning curve for digital subtraction myelography, but I do think that the technique is pretty generalizable, and it's a great technique. So get to the next slide. So, before I go on to the embolization now, just to highlight how important digital subtraction myelography is and what it's done for our practice. So we looked at our first, 60 or so patients that got DSM, and basically, we were pretty selective at first. So we didn't do that many patients with low burn SIH score. So the burn SIH score is basically a score based off of the MRI that gives you a sense as to what the probability of finding a CSF leak is. And there's a great article published by the Burn group who also does excellent lateral decubitus CT myelography. And basically, if you had a low probability of finding a leak off the burn SIH score, you had a low probability of finding a fistula in DSM. If you had a high probability, so basically, the decreased mammalopontine distance, effacement of suprasellar cistern, engorgement of dural venous sinuses, pachymeningeal enhancement, etc. We were finding leaks in about 67% of patients. And this was in our first 60 patients. I think the diagnostic yield has increased significantly now that we've done, a couple hundred. So now the treatment of CSF venous fistula. So, historically, when I say historically, I mean the past 6 years, right? The best treatment has been surgical ligation of the nerve root and vascular complex. So basically, a lot of these things are found from like T1 to T12. So these aren't like, except with the exception of T1, they're not essential nerve roots, right? So, here at Mayo, we find the CSF venous fistula. Then we do the, CT angiography of the spine to identify where a Adamkowitz was, make sure that Adamkowitz is not at the level where the fistula is. And if it wasn't, then the surgeon would go and then do a, hemilaminectomy and basically, tie off the nerve root, ligate the nerve root, and then, kind of just, cauterize all the veins of the nerve root vascular complex. So basically take the nerve root, the artery, and the veins, okay? And, for the first 44 patients that were treated, of note, 40 of these patients had blood patches and only one had improvement with blood patch. So this is just to highlight that blood patch does not help patients with CSF venous fistulas because the blood patch, it's not going in the vein. You're just kind of creating some local mass effect where the nerve root, arteries, and veins are. But in reality, you have a structural vascular lesion. You don't have a dural tear that's leaking into the, the interstitium. So blood patches don't work for these patients. Now, of these patients, 42 underwent surgery. After surgery, about 50% were headache free, and about a quarter of patients had 50% improvement in headaches. And on MRI, 23 had resolution of findings on MRI, and 7 had no change. And then postoperative events, about minor complications in about 30% of patients, like rebound hypertension, numbness, which makes sense. You're taking the nerve root, and then paresthesias or burning occurred in a sizable proportion of patients as well. Now it's not, these aren't completely benign. Some patients, they get severe like allodynia, like they can't wear a shirt, or for women, like they some of the women have complained, they have a lot of pain when they're wearing their bra and everything. So it does create some issues, but surgery works. And this is important because it's a proof of concept, right? So that if you take that vascular complex, the vein, then you're going to have resolution of the CSF hypotension. So then the question is, could it be an endovascular option? So I had purchased this book a couple of years ago because my book fund, was, about to expire. And I just looked up everything that Renee Gingin has ever written. And this book came up and I was like, whatever, I'll buy it, on spinal phlebography. And I was very interested because I was like, well, wait a minute, what's this spinal phlebography? So apparently in like the 60s and 70s, before the widespread use of myelography, the way that people would diagnose mass effect of tumors and discs and all that kind of stuff was to do spinal phlebography. So they'd go transfemoral, and then they'd get a catheter in like a lumbar vein or the azygos vein, and they inject super hard, and they'd get these phlebograms of the spine, and they would look to see if there's any displacement of structures and say, okay, there's mass effect at this level. And this would help with the neurological localization that people used to do as well. And, some of the pictures, from this book are just gorgeous because you see these paraspinal veins and they're dumping into the azygos vein right here. And if you think about it, I showed you those CT pictures earlier of the hyperdense paraspinal vein sign and the hyperintense paraspinal vein on MRI. So then it got me thinking, can a radiologist or can a neurointerventionalist catheterize the azygous vein and get into these paraspinal veins? And I just put it kind of in the back of my head. And then, this case occurred about 1.5 years ago, where, there's this beautiful CSF venous fistula at right T2. And you see this complex of contrast around the nerve root sleeve. And then you see this vein here getting opacified. This is the superior intercostal vein. And then it's draining into the azygous vein. So then I was like, well, there's got to be a way to catheterize this azygous vein, get into paraspinal vein, and then embolize. So basically, the idea from this nettergram would be to take a catheter, go, up the femoral vein, go into the IVC, get in the SVC, get into the azygous vein, and then find one of these paraspinal veins. And then once you have your catheter in the azygous vein right here, get into the paraspinal vein, and then get into where the radicular vein is. So these are the radicular veins that go along the nerve root, and then just close it with a liquid embolic agent, glue, onyx, etc. This is just a nice demonstration of the anatomy that I was thinking that we should target, right? So this is the radicular vein. It's running along the nerve root sleeve. Then it enters the nerve root sleeve. And then inside the nerve root sleeve, you have these arachnoid granulations which help with the CSF resorption. So if you were to close this vein off, with onyx, or at least close this vein off right here, then you'd create enough venous hypertension so that the CSF leaking from these dysfunctional arachnoid granulations would essentially stop. You've created a little bit of local venous hypertension. And, one thing is that there's a lot of redundancy in the spinal veins. It's a lot more redundancy than we see with the arteries. So, and then I also know that when they just take the veins surgically, there have not been any delayed complications related to like congestive myelopathies. So, I figured as long as you don't get your liquid embolic agent, to the level of the cord, you shouldn't have too many issues. Now I'm going to go over the angiographic anatomy in a second. So basically the steps of the procedure would be getting your catheter in the azygous vein. Now, where's the azygous vein? The azygous vein, you can actually see it on like chest x-rays right above the right main stem bronchus. So what I do is I get my vertebral catheter up to where the right main stem bronchus is. I point it posteriorly, and then I just use a glide wire, angled glide wire, and poke until I see it go over the azygous arch. Then once I'm in the azygous vein, do the azygous venogram. And here you can actually see those intercostal or paraspinal veins that are trying to enter the azygous vein. They have valves. They do have valves. And then get into the veins, the paraspinal veins with a microcatheter. You can see here these beautiful paraspinal veins on the lateral projection and how they're running, in the paraspinal space and then dumping into the azygous vein. And then close that vein off, both the radicular vein and the paraspinal vein, with onyx. So those are the steps of the procedure. And I'll show you a video of a procedure as well. So this is from that case that I actually did yesterday, and this was great because it shows the anatomy more beautifully than any case that I've done so far. So this is a benchmark catheter. I mean, I'm not saying you have to use a benchmark catheter. You can use an Envoy, a Chaperone. You can use a Vert catheter. The first 20 cases, I just used the Vert catheter. So the benchmark catheter is going up the IVC, and now it's in the azygous vein. So this is the venogram, right? So the blue right here is the azygous vein. So that's the azygous vein. This is where all those paraspinal veins are dumping into, okay? So azygous vein. Then these right here are the paraspinal veins. So they're running along the spine. They're running along the vertebral body, okay? So paraspinal veins, okay? Now, these little holes right here that you see in the veins, like right here, this is actually where the nerve is coming out. So the nerve is circled, it's encircled completely by the vein. So these are the radicular veins. So this is your target. This is what you want to close. You want to close the radicular vein. If you close the radicular vein and the paraspinal vein, then you've accomplished, your task, mission accomplished. And then, these veins, so this is lateral, right? So this is anterior, posterior. So these veins right here are the epidural veins. So azygous vein, paraspinal vein, radicular vein, epidural vein. I'll show you the anatomy one more time. Azygous vein on the AP, azygous vein on the lateral, paraspinal vein, paraspinal vein, paraspinal vein, paraspinal vein, radicular vein, radicular vein, epidural vein. That's the anatomy that you need to understand. You also need to understand there's a ton of redundancy. And that's the reason why I like the onyx, because onyx accounts for redundancy. Also, remember, glue goes in the direction of flow, and the flow is against where your catheter is, because the vein is draining into the azygous vein, right? So I think if you inject glue, it's just going to reflux back. But onyx, as all of you who've used onyx know, it goes exactly where you would not expect it to go. So that's why I like to use onyx. And it permeates all these things, okay? So here's a case from yesterday. Here is the myelogram, unsubtracted. I kind of inverted the colors because I think it shows it better. Here's the nerve root sleeve here's the nerve root diverticula. Here's the radicular vein that's we're having the CSF leak into. And it's going into the paraspinal vein, but it's also going into like this intercostal vein, and it's also kind of anastomosing with the vein below too. Exact same thing, only this one is, not inverted color, but exact same anatomy. And then here is the venogram. This is probably where the nerve root diverticulum is. Here's that radicular vein that's opacifying, going into the paraspinal vein, and then it's going into a little more of this radicular complex. And then here's the onyx cast, a little bit in the epidural space. That's okay. Radicular vein, paraspinal vein, and that whole complex. And I got the thing that was going low, and I got the thing that was going just a little bit lateral too. Again, review of the anatomy, IVC, azygous vein, paraspinal vein, radicular vein. There's a ventral and a dorsal. And then, there's some other veins that go to the ribs, go to the spinous processes, etc. So anatomy, very important. You need to know the anatomy if you want to be 100% sure that your onyx cast is right where you want it to be. This is the post CT from this patient. Ventral, dorsal radicular vein, and then some of the onyx got in the bone, and then here you can see the paraspinal vein, getting filled with the onyx as well. Before I show the operative video, does anyone have questions about the anatomy?
I'm sure there's going to be a lot of questions. There is some question already about the technique, but why don't you go ahead and then?
Yeah. Okay. So now, we have a very busy leak practice here. It was started by this guy, not this guy, I mean this gentleman, Bahram Mokri, who came here in the 70s, And he established the CSF leak practice at Mayo along with one of our surgeons, David Peepgrass. So we see a lot of patients for this disease. So the first 5 cases that I did, the first 15, 20 cases I did, I just used a vertebral catheter, again, the azygous vein, and then just kind of put a headway duo out. But I've since kind of refined the technique because I wanted to get the best onyx penetration possible. So this is kind of how I do things now, okay? So here's a video. This is the azygous vein catheterization. I have the vert catheter pointed posteriorly, and I'm using a glide wire, and I get the glide wire into the azygous arch. And here you can see the wires getting caught on a bunch of things. Those are the paraspinal veins. It's very easy to get into them. Now what I've done is I advance the vertebral catheter just a little bit in the azygous arch to provide enough support so I can get the benchmark catheter up into the azygous vein. Now, why do I use the benchmark catheters? I was having issues with the stability of a standard diagnostic catheter. And I just wanted, to own the vessel and not have to worry about stability issues, because sometimes getting into the paraspinal veins can be a little difficult because they have valves. There's multiple valves along the way. So your wire will hit the valves and you have to just keep manipulating until you get the valve open. One trick that I use to get the valve open is that I have the patient take a breath in. Most of the cases I've been doing without general endotracheal anesthesia, but if you do it with the general anesthesia, you can just have the anesthesiologist have the patient take a deep breath in. So then I get my benchmark catheter into the azygous vein. Now, in this case, it was a right T12, so I'm getting it down as far as I possibly can. Then I do the venogram. So now the venogram, I showed you guys the anatomy before: azygous vein, paraspinal vein, radicular vein. Okay, so I did the venogram. And then I've been using the scepter, because, I think, you can basically, keep from getting reflux into the vein, into the azygous vein. Because, some of the onyx can get into the azygous vein. It's not that big of a deal. But, just to avoid, having tiny pulmonary emboli. So now you see the wire that's in the paraspinal vein, and I have my microcatheter right here. Now this is important. Okay, my target is the radicular vein. Okay, the target is the radicular vein. So I want to be close to the radicular vein. That's where you want your microcatheter. You don't want it sitting just in the paraspinal vein. You don't want it distal in the intercostal vein. You want it close to the radicular vein. Now, I think it's hard for the thing to make the bend into this small radicular vein, and I don't want to rupture the radicular vein, because then is the onyx going to go there or not? I don't know, right? So I'm very gentle, but when the wire starts going, this is the pedicle, right? When the wire starts going just a little bit medial, then I know that I'm close to the radicular vein, because there's only one vein that's coming out right here, and that's the radicular vein. So the wire is going a little bit medial, so I know I'm okay. Leave my microcatheter there. Now here, I just want to show, so this is the balloon catheter, the scepter. Here's the scepter, here's the tip. Here's the venogram. So the tip of the catheter is right where that radicular vein is. Here it is on the lateral. Here's the tip of the catheter. Tip of the catheter is right here, right where that radicular vein is. So then I do the venogram. Perfect. Radicular vein, that whole complex, epidural vein, I know I'm in a perfect spot. Inflate the balloon. And the reason I've been going with this technique now is because I think you have to be aggressive about the onyx if you want to not have a recurrence or anything like that. Because if the onyx doesn't close everything, the veins will find a way. There's so many venous collaterals and so much redundancy. The veins will find a way to drain. Okay. So then I just start with the onyx embolization. some of the tantalum kind of precipitating the catheter, even with all the DMSO. And then I just start embolizing. This is at like 8x. I'm not, crazy with pushing the onyx, but you can see that I'm getting, all the veins that I was showing you. I'm filling all those veins. Now, the last thing I want to do is I want to close the whole paraspinal vein. I want to create a lot of venous hypertension. So then I deflate the balloon and just let it reflux back. And this is the final onyx cast right here. So now I'm going to show the results. So this is the series that was published in AJNR last week. This is from the first 5 patients. So first 5 patients, SIH, secondary DSM confirmed CSF venous fistula. All of them had brain sag. All had headaches. 3 had cognitive dysfunction. 2 lawyers. I'm very good at selecting my patients, as one of my partners would say. 4 with tinnitus and hearing problems. So here's patient 1. There's just this vein that kind of flickered on the DSM. I was not aggressive with the onyx, but I just wanted to see if it could work, right? Here's the initial MRI, all those findings of brain sag, pachymeningeal enhancement, MRI 1 month later, improvement in the brain sag, pachymeningeal enhancement resolved. Patient 2, these veins are getting opacified from that CSF venous fistula. This one was more aggressive with the onyx. Here's the pre-MRI, post. There you go, pachymeningeal enhancement gone, brain sag gone. Patient 3, this one was a hose. This was at T3 or T4, but you can see this vein, this was pulsating. That's how fast this thing was leaking. This one I tried transjugular. It didn't help at all. It just made things more hard because the supreme intercostal vein comes off the top of the azygous arch, and it is hard to get into. But here's pre, post. Another one. This one I was not aggressive with the onyx embolization. Here's the pre though. The brain sag improved. The pachymeningeal enhancement improved, but did not completely resolve. And then patient 5, this is like an incredible vascular complex, from the CSF venous fistula. And they also had one on the other side. So I did bilateral embolizations. This is pre. He didn't have that much brain sag, but they had dense pachymeningeal enhancement. But then here's post. So the whatever was there of brain sag improved, pachymeningeal enhancement resolved. And basically, of all the patients that we treated, 4 had complete resolution of all their symptoms. And then, 1 patient had 50% improvement in headache. That was the one that just had that thin rim of pachymeningeal enhancement. And then series to date, 25 patients. All of them were discharged the day of the procedure. So I've been doing this on an outpatient basis. 23 out of 25 had improvement in symptoms. 2 patients had persistent fistulae, probably due to not enough onyx. And I did retreat those, and we'll get follow-up on them. And then 3-month MRI follow-up on a majority of these patients is pending. Most common complication, embolization site pain. You are putting onyx there. We've been treating it with NSAIDs or steroids. None of the patients have required narcotics. We haven't had any major complications like no, disabling nerve dysfunction. I've had a couple cases where, on the post-op CT, I do one on all the patients. I could see a little bit of like little flicks of onyx in the lungs. But if you think about vertebroplasty, 30 to 40% of patients have cement in the lungs, and it's way more than what we get with 1 cc of onyx, but no PEs or anything like that. Then there's some technical nuances that I can get into later. But the cervical venous anatomy is a lot different than the thoracic or lumbar. Most of these are thoracic though. The T1, the T4 fistulae, there's some challenges related to those because the superior intercostal veins a little bit difficult to get into. These cases I do under general anesthesia. Catheter stability, I think that's solved with the benchmark. I've switched using balloon, And then choice of liquid embolic agent. If anything better than Onyx comes out, I'd love to use it. The issue with Onyx, though, as you know, is you get the porcelainization of the vein. So you can see the vein gets dark, but it doesn't mean the vein's occluded, because Onyx is not as inflammatory as like glue. So that's kind of it, and I'd be happy to answer any questions. I know I probably talked for way too long, so.
Thank you so much, Walid. This is incredible. This is incredible work that you did, and I mean it's such a. I'm so honored to have you talk about this here with us today. I mean it's a new another disease, right? That we're as neurointerventionalists we are potentially able to help. So this is very, very exciting. There's quite some questions. Most of the questions here are about the technique and one about the anatomy. So I will get to these questions. One of the messages that you said that, and I think it's paramount, is making the diagnosis, right? Because I think here in the audience we're probably all like very excited to try these and go there with a catheter and try to get to the radicular vein. And honestly, probably like it seems by the way you're describing, that's not the most challenging thing, the technical part. One of the most challenging thing though is the diagnosis, as you said, making this diagnosis with the lateral decubitus myelogram. Can you go again very briefly through like the technique of that, and then we're gonna get to the rest of the questions.
Yeah. So this is the Farb technique. This is what Richard Farb taught me, and just one thing, to anybody that's like a fellow or anything here, when I went to Toronto to do neurointervention, I went there because I wanted to learn how to do brain AVMs and dural fistulas and complex stuff, right? And Richard Farb was doing digital subtraction myelograms on Thursdays, and I was like, oh, what's this that you're doing? And and then he showed me and everything, and like the fellows were never involved with this stuff before, so it was completely by accident, but it was because because I had an open mind and was like, oh, this could be something that maybe I could help the CSF leak practice, which I was not involved in, and nobody was planning on me being involved in it at Mayo at the time. So keep an open mind, and you can just learn incredible things if you keep an open mind. But so the lateral decubitus myelogram, we basically take the patient, we put them on an angio table. We put them on their side, and we basically put some cushions under their hip or butt to get their butt up in the air a little bit, or their hip, or I don't know if butt's a bad word, I don't know, whatever. And we get their rear end up in the air. Okay. Then we take the C-arm, and basically have it point to the back and do the LP. Okay. So when we have the LP, we get some fluid back, and then I just hook up long tubing to the end of the needle. And then I put 10 cc's of saline in first, because I want to pressurize them and, basically increase provoke the leak, make it a little bit higher pressure. So maybe the leak will show up a little bit better. It's theoretical, but a little bit of positive pressure probably helps. And then, through the tubing, inject 5 cc's of contrast and center on the cervical thoracic area, and then basically do spinal, angiography setting on the DSA at 1 frame per second. You could do it at half a frame per second, but you don't need to go faster than 1 frame per second. And watch as the contrast goes in each nerve root sleeve. Okay. And then I go to the thoracolumbar area, center the detector on the thoracolumbar area, and then inject another 5 Cs of Omni 300 in the thoracolumbar area. Use Omni 300 because it's much denser than Omni 240. You know, a lot of these patients are bigger, you know, so you want to be able to see everything very clearly. And we look at the digital subtraction images. We also look at the unsubtracted images. And the unsubtracted images are actually often more helpful than the subtracted images, because there are a lot, there's motion with respiration and everything.
And do you look on an AP, a pure AP projection?
Yeah, pure AP. We don't do it as a biplane. So pure AP.
And then to do the other side, you do it right away, or you have to bring the patient back?
We bring the patient back the next day. You know, there are dose limits to Omni, you know, PAIC in the spine. I think it's like you can't get more than 300 milligrams in a day. Otherwise, it lowers the seizures threshold. But we do it the next day. And we publish our series on the safety of that. And we have not had any, like, outside of headaches, we haven't had any like major adverse reactions from that.
Okay, awesome. Okay, all right, so let's, okay, so one question that Ryan McTaggart has, which is like on this, before going to the rest, is like, he's saying how amazing this is, obviously, and he asked, where does physiology meet pathology? Is there a study of lateral decubitus myelography normal control where like we see this finding as an incidental finding? I mean, not symptomatic.
Yeah, that's a good question. I don't think that there's a study on lateral decubitus myelography in normal controls. I will say that, you know, this is unpublished, but, you know, we do, you know, just tons of CT myelography here, you know, the spine group. And, you know, there are a few things on CT myelography that you can see that suggest the presence of a fistula, right? Number one is obviously the hyperdense paraspinal vein sign. That's the smoking gun, right? But the other thing, which is the bullet case, is contrast in the renal system. You shouldn't have contrast in the renal system after doing a myelogram, because unless there's a connection between the vein and the CSF, you know, like, but within 10 minutes of doing a CT after myelogram, you shouldn't see that. But when we've done myelography for orthopedic indications versus diagnosed CSF leak, it's basically like less than 1% of cases do we ever see contrast in the renal system when we're doing myelogram for orthopedic indications. So this suggests, I think, that this physiology is pathologic and is not normal. And the other thing is that rebound hypertension after treating these things is not that common. But I think that if you were to occlude a main source of CSF egress into the vein that was physiologic, that you would get more intracranial hypertension after doing this. But it's theoretical, right? But yeah.
Okay, good, excellent. Moving on with some more anatomical question. I will have mine too. But Michel Pioten is asking, is there a preferential side, right or left, for the leaks?
We're seeing a huge right-sided predominance, like 80-20. That's good because the right-sided veins are much easier to get into. Yeah, we're seeing huge right-sided prevalence, and you know, I wonder if it's got I'm not sure why, but you know, if you think about it, our dural venous sinus system, for most people, we're right dominant, and I think most arachnoid granulations in the brain are on the right side, and I wonder if most of these arachnoid granulations in the spine are on the right side. And this kind of lends more credence to the idea that these could be due to dysfunctional arachnoid granulations. But yeah, huge right-sided predominance.
And so to follow up with this question, Yet most of the cases you showed were indeed, at least the technical details were on the right side. On the left side, you said it's more difficult because, I mean, there's the hemiazygos there. Is it always accessible through the azygos, or it's possible that another route has to be taken?
I think another route might need to be taken for those cases. There is, on the left side, there's a vein that comes off the left common iliac. It's called the ascending lumbar vein. And that does actually connect with the hemiazygos system. So, and it's actually very easy to get into that vein. You know, but I'd say from like T5 to T12, all those paraspinal veins are draining into the azygos vein. From T1, like left T1, that's going to drain into the vertebral vein or the paravertebral vein that comes off of the left brachiocephalic vein. And then T1 through T2 to T4 in most people come off the accessory hemiazygos vein. I have not had any cases of left T2 to T4 yet. So I haven't had to figure out the accessory hemiazygos vein, but I would recommend, if you're going to do this, just get a venogram of the area of interest beforehand and study the anatomy so that you can actually get things
CT venogram? What do you mean by venogram?
Oh, a CT venogram.
So you said you get it regularly on your patients?
I get it if it's like a high lesion, like, you know, T1 to T5. I get a CT venogram, but the other ones, you know, it's very easy to get into, you know, T6, 7, 8, 9, 10, 11, 12, very easy to get into the lumbar ones. But getting a CT venogram ahead of time can really help you understand, just to give yourself a sense as to where you're going, you know, so that you're not going into it blind.
Okay, excellent. So I'm not sure who's asking this question, but I don't know, maybe it was Kitty Pong. Question is, are these radicular veins you're talking about the actual radicular veins that drains the spinal cord, as in the illustration you showed? Because he says, I think they can be just any vein surrounding the nerve root, not necessarily draining the spinal cord. Is my understanding correct? It seems correct, but
yeah, I don't think that these are necessarily the ones. I guess when I say radicular vein, you know, it's not, I don't think it's necessarily the vein that's going along, you know, the nerve root intradurally and then
not the radiculomedullary vein.
Yeah,
it's
yeah.
the radicular vein.
Yeah, so I guess it's going along the nerve roots. I guess I'd call it a radicular vein because it's going along the nerve root. I think there's enough redundancy in the spinal cord venous drainage system that as long as you're, you know, not getting anything midline, that you're not going to cause any type of, you know, radiculomedullary venous congestion. Yeah, it's something that I do, you know, it's in the back of my mind every single time when I was thinking about this. But then I thought about how the surgeons going in there and taking the whole thing, you know, without, you know, looking into that, and, you know, between Shivink and Atkinson, you know, there's been no reports of anything, you know, like spinal cord venous ischemia happening after this surgery. So I don't think that getting onyx, you know, around the nerve root sleeve is going to cause, you know, problems.
Okay, excellent. Now we're, if anybody in the audience has any question about the anatomy, before we move to the questions about the technique, please unmute yourself and go ahead. Otherwise, give another few seconds. Otherwise, I move to the questions about the technique. One is more like about the angiographic part of the technique. Lal says, really impressed. Do you ever see reflux of contrast toward the CS, like interarticular contrast reflux, when you do your venogram, being an indirect sign of the right level? Or do you just start with the right side, and then if you find a CVF stopped and not do left. I'm not sure exactly what.
Oh yeah. So
do you understand the question?
Yeah. So
Okay.
we do bilateral on everybody, because there's, there's just the possibility that there could be something that could be multiple, right? I mean, it's rare, less than 10%, but it's there. These patients have been through a lot before they get to us, and people come from far away. So we just do the whole workup, and we actually start with the left, even though they're more common on the right, because you don't want to have the satisfaction of search. So we always do left, then we go right. Then regarding intrathecal contrast reflux, I've never seen convincing evidence of contrast going into the spinal, into the CSF when doing the venogram, and I've never seen onyx in the CSF after the embolization, and I do CTs on every single patient, because I do a post-op CT either on the table, or if they're a little larger and I can't do it on the table, I do it in a conventional CT scanner on every single patient. And I haven't seen it yet.
Okay.
But that's the most common question that I get asked. So.
Okay. All right. And then there's a question by Anish Kapadia. Do you require liquid embolic, or do you think coils can be as well, as good?
I don't think that coils would work, because I think it'd be hard to get coils into the radicular vein, number one. Number two, there are multiple veins. There's a vein in the front, there's a vein in the back. So, and you're not 100% sure where the leak is, and there's so much redundancy in the system. So I obviously coils are so easy to use, right? But like I think it's like coiling, it's like putting coils in an arterial feeder of a brain AVM. I mean, in the, maybe you create a little bit of, if you put some coils in the paraspinal vein, maybe you create a little bit of venous hypertension, but there's so much redundancy that you probably haven't done a huge, you probably aren't not having a huge effect on the venous drainage system.
Yeah, it seems reasonable at that point. Once you get there, get the whole thing closed. And Aslan Fendizade is asking, if embolizing within the root sleeve, is there concern for mass effect of the cast upon the nerve or artery? Have patient reported positional dynamic symptoms?
Yeah, no, I mean, yeah. So patients have reported kind of that, they get like soreness or pain, kind of, and it's usually like at the site where the onyx is. That has been, that is something that's, probably, probably 20% of the patients are reporting. Arterial compression, haven't had that issue, I guess. I guess it's no different than when you're doing, if you're embolizing like a dural fistula on the spine or something, or epidural fistula, I mean, sometimes you're putting loads of onyx in there and people can get some pain in that area.
Yeah. Ben Scoffing was asking essentially the same question. If you see like reverse flow into the subarachnoid space, and then you already answered that. And then Omar Kashout asking, is direct stick an option? Yeah,
so that's a good question. Now, there's a couple reasons why I wouldn't do direct stick. So number one is, I think it's difficult to get in these little floppy veins, through direct stick. That's number one. Number two is if I puncture the vein and get in the azygos vein and get a microcatheter in a paraspinal vein, I'm 1000% sure that I'm in a vein. And one thing that can happen under CT when you're doing like a direct stick is that, you know, your needle could be in a vein, but you probably punctured the artery on the way in, or you might have punctured the artery on the way in, or the needle moves a little bit and then, you know, kind of hits the artery, right? And then you're doing your onyx embolization, and, you know, you just don't know if you've done anything to the artery on the way in, right? And, you know, what could happen, I think, is eventually, you know, maybe, you know, you just get unlucky and you might have, you know, pulled back in an artery, or maybe you've created like a little arteriovenous fistula with your needle, and some of the onyx goes in the artery, and, you know, you hit a radiculomedullary artery. So that's why I don't want to do things with the direct stick. The other thing is that onyx, I like personally, I don't do like vertebroplasty under CT, because I just want to see where things go in real life, in real time. And it's difficult to get real-time pictures on CT. So with onyx, you know, you want to watch the onyx. Every time you push, you want to watch, you want to see exactly where it's going. And you just can't do that with CT. Granted, you know, I mean, some people might be excellent CT interventionalists, and will do this direct stick, which is great. You know, I look forward to seeing that. But I like, I just like knowing that I'm in the vein, and plus I can control I can control my time in the angio suite. You know, CT I don't get to control. You know, when I can do stuff on CT. So
I mean, also,
yeah.
I mean, you said the artery, but another thing that makes sense is the nerve. I mean, you're working around the nerve.
Yeah.
So you can certainly like hit the nerve, which is exactly the reason why this is better than surgery, because we can preserve that.
Yeah.
Okay, good. And were there any other questions? I mean, there was a comment by Sid that he did a direct stick MBCA into an S1 perineural cyst, I guess, associated with CSF leak.
Yeah. That works. You know, we do those for like nerve root tears where people have these perineural cysts that are leaking. You know, we'll direct stick, fibrin glue, MBCA, etc. You know, our spine interventionalists do a lot of those cases, and that's absolutely something, you know, that'd be amenable to direct stick. You know, and there's one patient that had a CSF venous fistula at S1, who, you know, obviously the surgeon was like, well, I'm not going to operate on this. It was like 2 or 3 years ago. And you could see the internal iliac vein getting opacified and everything. So we tried blood patches, but it didn't work because it was a CSF venous fistula. But I tracked the patient down and called them about this option. So I'm going to try that one. Maybe that could be direct stick, but I'm probably going to try to get in the internal iliac vein and find the vein and embolize it that way. But I think direct stick for like sacral stuff is excellent.
Excellent. Any other questions? Anybody wants to take the microphone and ask a direct question or add any other comment? All right. On this note, I thank you again for this amazing stuff. And NeuroIR is growing and growing. And we're able to help more patients thanks to your technique now.
Oh yeah, no, thank you. Yeah, no, this is like the most, you know, I mean the case series that got into AJNR, I was telling my wife yesterday, I was like, you know, of everything that I've done, the thing I'm most proud of is this case series of 5 patients. So that, I mean, I think, I mean, this is something that you're gonna, if you do this, you're gonna change people's lives.
Yeah.
Because these people are suffering so much, and you're going to change their lives. And you know, the gratitude from this patient population is it's unlike anything that I've seen from any of my other patients. All patients are always grateful, but this is something where you're really just, you know,
yeah,
it's a monumental impact on these people's lives.
Yeah, that's the difference on treating an unruptured aneurysm, right? Which, yeah, Yeah, I see Henry ready for a question.
Do you have a neurologist who who you work with, who evaluates these patients on a long-term basis? I mean, or are you doing all of that yourself as well? Because many of these patients, I mean, they get categorized into like the pseudo tumor patients and stuff like this. And a lot of times it's more than just, yes, every once in a while they can be the one cure and they're fixed, like transversinous stenting for idiopathic hypertension. But a lot of times there's a lot of, vague symptomatology that needs to continue to be followed. So is there a neurologist who's following them?
Yep. Yeah. So, we have a great team. We have a CSF dynamics clinic here that has, like 3 or 4 neurologists that are seeing these patients. That's where we're getting the referrals from. These are the ones that are following the patients. So like generally, I do the 3-month follow-up, see how they're doing. But there's a whole host of other issues, that need to be sorted out. And it's a team. Like the neurosurgery practice, super supportive. The neurologists are huge. You can't do this in a vacuum.
Yeah, I assume that you would need an infrastructure in order to coordinate and organize these patients and stuff like that. So, okay.
Yeah.
Very nice talk. Great job.
On this note, Walid, like this is it doesn't how many centers you think like let's say in America are needed for this disease? Because right now we know there are like these few centers like yours, Duke, Cedars-Sinai you mentioned. I mean, there's probably another couple that I'm forgetting, but a few centers specialized generally in CSF leaks, right? And is that enough? Do we have just to say whatever? If I have a patient tomorrow, I'll send it to one of these centers, or you think there's more need around? Yeah, I'm always happy to take referrals. So anyone, if you want, honestly, like if you have patients that need the multi-specialty care and the neurologists and all that, I think that any center that can establish the infrastructure to do a high quality digital subtraction myelography, have excellent neurologists that are astute in diagnosing these patients and managing these patients and following them up. Surgeons who are comfortable operating on these patients, especially like the ventral tears and stuff like that. And obviously, neurointerventionalists and neuroradiologists who are doing a lot of these procedures. I think it's going to be the big, academic centers to start, kind of like how spinal vascular malformations in the 80s and 90s and early 2000s were, really getting seen at a few places. It really does require multi-specialty care. However, the disease is common, and the patient that I saw yesterday and treated that, I treated her yesterday. 5 years she's been suffering from this because of misdiagnosis until she came here. So it's important for everybody to at least be aware of the disease. Regarding who treats it, who does the entire workup and everything, it's going to depend on infrastructure and experience. I can't answer who should and shouldn't be doing it though. Yeah, no, how to say, is it how rare disease? And you're saying it's not actually that rare. That essentially was my question. Like, yeah, I think it's more common than we expect. Yeah. Okay, good. All right. Any other question? Or Luca, are you ready for the case? Luca.
Ciao to everybody. Yes, I'm ready if you want.
All right. So thank you, Walid. We're moving to cases. I hope you're going to stay with us for that. Yeah, and, absolutely. Whenever you have a case also, we're always as Max said before, anybody with cases, please, okay, let me pin you here. All right, here we are. Are you available to share your screen, Luca?
Yes. Can you see?
All right, so Luca Quilici from Bergamo.
Right. Neurointerventionist from Bergamo, but this is an old case, 5 years old case that came in Niguarda in my old life, previous life. It was a 75 years old man that arrives with an orthostatic headaches, vertigo and tinnitus, but we know later that tinnitus came out 1 year before this event. But the headache and the vertigo had an acute onset 2 weeks before. This is the CT scan. And as we saw in a very wonderful way, thanks to Walid, this is his CT scan that show hygromas, bilateral hygromas, the small dimensions of supraventricular, supratentorial, the ventricular system, and compression of all the subarachnoid space on the convexity and on the base. It seems to be quite an hypotension CT scan. Maybe even the hyperdensity of the deep venous system could be a sign. We went for an MR, and these are just a selection of some images. And you can see on T2, the hygromas, the small dimension of the ventricular system. And at the base, the skull base, you can see a lot of little tiny tortuous images, flavoid. In the gradient, it's the same. You can see the hygromas and a lot of little like snakes, little snakes in the skull base and in the white matter of the brain. After the contrast, you could see a pachymeningeal enhancement. The cisterns are small, and on the other planes, you can see better and better that it's a classic MR scenario of hypotension. That with the clinical scenario, even too, with the headache, orthostatic headache and vertigo could match very well. You can see the pons against the clavus and all the stuff of hypotension. Even the splenium of corpus callosum is rotated downstream. So for us, this was the diagnosis, CSF hypotension with many vessels. And obviously when we saw a lot of vessels, we think to do an angio. And this was the surprise. It was really a surprise because we saw a lot of vessels, but we couldn't imagine that we're facing things like this. It was a fistula, arteriovenous dural fistula, type 2, together with a side CSF hypotension, we think. Do you agree?
Absolutely. We've seen 3 patients with this exact presentation. I have one patient, that exact same MRI that your patient had. And I only know that she's not the same patient because you're in Italy, and I don't think she's ever been outside the country. But
do you include the paraspinal vein?
No, but go ahead.
Yes, but how can you join together the two things? Because I would stop. In my head, my topic could stop here, because I think this is the main problem. Well, how can you connect together a dural fistula that obviously and often gives an hypertension, intracranial hypertension, because gives a reduced absorption of liquor. Instead, we have an hypotension, a CSF hypotension, a clear scenario. So how can you put together this? And this is a question for everybody. do you believe that they are disconnected, these two problems, or they are connected? And
So
I
so
thought to-
there was so the prevalence of dural venous sinus thrombosis in patients with CSF hypotension is about 2%. We looked at our last like 500 patients over the course of 20 years that had CSF hypotension, brain MRI, brain SAG, and about 2% had dural venous sinus thrombosis. There was a similar paper from the Cedars-Sinai group that I think it was like 3 to 4% of CSF hypotension patients had dural venous sinus thrombosis. And I think it's because the veins get, I don't know, right? But the veins get dilated and they get more capacious. And I think that when the veins get bigger, there must be some, like loss of laminar flow or everything, right? That causes, the, more prothrombotic milieu. So I think it goes hypotension, venous sinus thrombosis, dural fistula. That's what I think, but I'd love to hear other people's hypotheses.
Yeah, I agree, but there is a mismatch between the aspect of the dural fistula, the development of this dural fistula. It seems to be there more or less since 5 years, not 2 weeks, because the patient was well conditioned until 2 weeks ago, until 2 weeks before this event.
Oh, okay.
For 2 weeks, he were completely normal. So it's difficult to put together the young age of the clinical scenario and this type of fistula seem to be there 2, 3, 4, 5 years, and it developed itself. So maybe, yes, it's possible. It means that he had the hypotension 5 years ago, and he has not any sign of it. Agree?
Yeah. There are patients that get intracranial hypertension and then get like skull base CSF leaks from the intracranial hypertension. They get like encephaloceles, and then they get these CSF leaks from that. I've seen one patient so far that had intracranial hypertension from dural venous sinus thrombosis, and then got a spinal CSF leak, maybe from the hypertension, I don't know, but then had hypotension. And then the surgery ligated the CSF leak, and then the patient developed severe rebound hypertension that was refractory to optic nerve sheath fenestration, dural venous sinus stenting, and the patient ended up needing to get a shunt. We should report that case, and maybe we could combine, forces, but I think that that hypertension can lead to spinal CSF leak and hypotension as well.
The hypothesis of mine and of Dodi were like this, that the dural fistula gives an hypertension, the hypertension gives a tear of the dural sheath somewhere, and then the hypotension. But obviously we have no proof of it. And we fight in that days with our neurologist to do before the blood patch or before the endovascular treatment. But the patient decided for us, because he had a progressive in-hospital consciousness deterioration. It was up and down, in coma outside. So the pressure of the liquor was normal. So we decided to go for a treatment. 2 or 3 days later, after the charge in hospital, and this is the treatment. We put the microcat in the middle meningeal artery, and then with the protection of the balloon of the transverse sinus, we inject a lot of onyx. If I remember, 9 millimeters of onyx. It was a huge injection. Everything went well, and this is the last run with no problem, no remnant of the fistula, and the patient improved, had no more headache, and he wake up from the coma. So he was put in heparin for a week, if I can remember, 6,000, and discharged 1 week later. But, and this is the unexpected event, he had a new event 1 month later. He had headache and left arm disgestation. What has happened? This is the MR immediately after the day of the charging hospital in the AR. And you can see a little bit of a subarachnoid hemorrhage, again with the hygromas. I go back just a little bit. But if you look with attention, you can see that some signs of the hypotension are solved, are improved, were improved. Obviously, we repeated the angio just to see if there are some remnants of vascular problems, and we found no remnant, no problems of the fistula, but we found an area of latent venous drainage, and we found that a vein thrombosis that, as you said, could be joined very well with the hypotension. But again,
it was new. It wasn't there on the prior angiogram.
No, but it was a correct answer, Ethan. It was a vein that drained on the convexity, a part of the fistula. So if you see here, maybe it is this. Maybe it's joined, but yes, could be a problem of the stopping of the heparin that could be necessary to continue, to not discontinue, but we don't know. And we found this vein thrombosis, and then unexpected, we fight again with our neurologist that he decided to do a blood patch because he don't want to do again heparin with the subdural heparin, with the subdural hematoma, with the groma. And this is the CT scan before the blood patch, immediately after some days after the new entrance in the hospital. And as you see, as I said before, it seems to be partially resolved, the hypertension. This was 1 month before. And this is after the treatment of the endovascular, after the treatment of the fistula. And as you see, the ventricular system is larger, and you can see better some subarachnoid space. This is the comparison between the MR on up the first one before the endovascular treatment and down the second one. The hygromas are more or less the same, the global mass effect, but despite this, you could see better the ventricular system, even on the posterior fossa, and you could see better the sulca at the top. We did a follow-up with MR, with the CT scan, and he completely recovered from any symptoms, any sign. And after 8 months, we did the MR. We no more sign of hypotension or venous hypertension from the fistula. I don't know. This is, for me, it's a very interesting case because we have 2 points: how to join together a pathology like fistula that gives normally an hypertension, even not only on the venous compartment, but even on the liquor compartment. And the other things is how to. It was before the eggs or before the chicken. Who started to give the problem? Who is the beginner? And anytime in Val d'Isère, even the last year, Dr. Higgins showed some cases of brain slump caused by venous stenosis at the level of the neck. And now he published a new work on the surgery of styloid prosthesis that gives, like a Eagle syndrome, that gives a stenosis on the venous jugular veins that could give venous hypertension on the brain that then gives a tear on the dural sheath and then an hypertension of the liquoral hypotension. But despite this, I couldn't see your cases valid because I looked for dural fistula and hypotension. I just found this article that speaks about a spinal vein enlarged on the posterior medullary compartment, and the spinal vein is associated with hypotension, but they did not do an angio, and they explain the combination between hypotension and enlargement of the spinal vein with the Morrow-Kelly law, in which if you have a dilatation of the epidural space, you could have a reflect on the intradural space hypertension. I don't know, but yeah, the case is finished. Thank you.
Thank you. No, this it's pretty interesting and on the topic. Yeah, you know, like Walid mentioned the theory of patient with leak tend to develop thrombosis a little more. I mean, 2% he said, but those ones may then develop a fistula on top of the thrombosis. The other theory that you mentioned, and I see also Lal and Thais Minette kind of mentioning too, hypotension. There's essentially like a dural fistula with hypertension, and that induces a leak. It's the hypertension itself that induces a leak. So you know, yeah, it's probably so rare cases that it's hard to get to the answer easily. But this was pretty interesting. Any comments? Any question on the case from anybody? Right. Excellent. Should we move on? We have a case from Keisuke. Keisuke, are you there?
Hey, yeah.
Hi, how are you?
Hi. Before I present about tumor embolization,
Can you share your screen?
yes, I'd like to share one CSF leak case before I start.
Sorry, repeat. What do you say?
This is a slide. This is a slide made for Japanese meeting.
Okay.
But in our hospital, we had a CT, upright CT, which we can take CT in a standing position. So in the standing or sitting position, intracranial hypotension exacerbate, I think. And this was interesting. This compares spine CT and upright CT. And we see venous engorgement that we could not see in the spine in the upright CT. So I think upright imaging might be helpful for diagnosing intracranial hypotension. But this is only one case, so I would like to accumulate more cases from now on. Anyway, I'd like to move on to my embolization cases.
What do you use? What do you use it right now for this standing CT? You showed the spine cases. Is there any other condition in which you prefer to do that? Keisuke?
Any neurosurgical patients can,
Okay.
can have an examination. So
okay. You have to share your screen.
I'll talk about fusion imaging for vascular assessment of intracranial tumors.
We don't see your screen anymore. Not sure if it's me. I cannot hear you. Anybody else can hear me? So I know it's not me. Okay. So we lost Keisuke. We give another few seconds. Otherwise, I believe Dodi has a case. Dodi, do you have a case?
Hello.
Let's give just 1 minute. Oh,
yeah,
there.
yeah.
Okay, Keisuke, can you share your screen now, please?
Okay.
Okay,
Can you
good.
see my screen? So I'd like to start my presentation. So last time I talked in the Bananaz session, I talked about the pterygovaginal artery anatomy, and it was recently accepted in neuroradiology and just published yesterday. So I'd like to thank Banana members. Today I would like to introduce Conbeam CT fusion technique. We know Conbeam CT images or slab map images reconstructed from 3D array can provide detailed anatomical assessment with high spatial resolutions. But single CDRA data can provide only one arterial system territory information. However, deep-seated brain tumors like skull-based meningiomas are often supplied by multiple arterial systems. So fusion of Conbeam CT images is useful. ICFA feeders need to be more carefully observed and is challenging to embolize. So information about contributions from each arterial system and tumor vascular compartments are very useful. So case one is a 47-year-old woman with headache and dizziness. MRI showed right petroclival tentorial meningioma. In angiogram, you have three feeders from ECA systems: MMA sphenoidal branch, AMA posterior branch, and occipital artery mastoid branch. Here's a stain. And this is the Conbeam CT image. MMA feeder is recurrent course to the tumor. And there are three feeders supplying the tumor. And also two feeders from IC systems, from ILT and MHTs. This is the Conbeam CT image and showing the tumor stain. So there are 5 main feeders from 2 arterial systems. So we made a fusion image, and the fusion image showed vascular tumor compartments clearly that anteromedial part of the tumor is supplied by the ICA, and the posterolateral part of the tumor is supplied by ECA systems. And these two MMA feeders and ILT feeders run very closely, but have slightly different courses and have no anastomosis. We embolized each feeders after provocation test with large particles and proximally occluded the feeder with coils. But the MHT feeder could not be catheterized, so the tumor stain from MHT remained. This is a post-embolization CT showing coils and devascularized compartment originally supplied by ECA systems. So MHT feeder is remained. So the tumor stain from ICA system remained. We did an surgery via lateral suboccipital approach, and the tumor was completely removed. This case 2 also shows that tumor compartments. This is a 48-year-old woman with right petrotentorial meningioma. VAG, vertebral angiography, showed pile feeders from PCA and SGA, and also ICAG showed ICA dural feeders. So fusion imaging showed the outer part of the tumor supplied by PCA and SCA pile feeder, and internal compartment is supplied by mainly supplied by ICA systems. So we had these feeders, and we could embolize these feeders. So in the operation, we could know the devascularized tumor compartment. So we removed the tumor safely via anterior transpetrosal approach. This is a postoperative MRI. In case 3, this is a 51-year-old woman with again left petrotentorial meningioma. And this case was interesting because the feeders from ICA system and ECA system had anastomosis. And this fusion image shows the connection between ICA dural feeder, and this is an accessory meningeal artery depicted in red. So AMA feeder and MH feeder had anastomosis. This is an axial section, and this red one is an accessory meningeal artery, and this blue one is an tentorial artery from MHT, and anastomosis exists in here. So we could confirm this with microinjection. We catheterized MHT. We could only catheterize this feeder origin, and injection showed tumor stain. And after particle injection, tumor stain decreased. And this vessel appeared. And when we move on to AMA embolization, we see this vessel, same vessel here. this is anastomosis between AMA and MHT feeder. We embolized MHT feeder proximally with coils, so we could embolize safely this tumor compartment. So this is ICA, injection first. And after injecting particles, we see this vessel anastomosing with AMA. We see the hearing coil and the AMA was feeding this compartment through the anastomosis with tentorial artery. So we could see anastomosis with fusion imaging. In the coronal section, you could see here at the tentorial margin, 2 feeders were anastomosis. So after embolization, all the tumor compartment was devascularized, and lateral suboccipital approach was effective in complete resection. So we did like this technique for many tumors and found that it's especially useful for skull-based meningiomas. Thank you so much.
Thank you. Thank you, Keisuke. These are amazing images. You know, like they prove a point that, you know, you proved it with catheters also in this last case. You know, these there are these connections between the vessels supplying the tumor. This that you showed well on this fusion are, you know, are big enough to be seen on the images, but the experience by doing this is that there are also like smaller connections that, you know, they're not like I would say microanastomosis within the tumor that open up during the embolization itself. So at least, and I'm happy to hear other people experience in the audience. But you know, sometimes like you embolize a part of the tumor, even if you don't see such a big arcade connection. You know, once you embolize part of the tumor, then small anastomosis start to fill the rest of it. So you know, I think that's also something to keep in mind. I mean, the images are awesome. So you do these are what machine do you use? Is it a Siemens or a G?
Philips.
Philips.
Philips Azurio.
And you can fuse as many volumes as you want.
Only 2 data sets.
Only 2 data sets, and I think it's the same with Siemens. Which is, you know, in some ways that can be a limitation, right? Because you know, it can be, you can easily need more than 2 volumes, and then you give different colors to them. I understand. Okay, cool. I see Kitty Pong ready for a question.
Well, beautiful pictures. By the way, we use GE machines, and they can fuse up to 12 images onto the same, you know, picture. I have like comments, or rather a question. I'm not sure, when we embolize meningiomas, sometimes we see like real compartments, but what you showed, maybe it's only like distributions of the, you know, the supply. It's not the real compartments. There's no real separation between these compartments. What is your opinion about this? I think sometimes we see real compartments because we inject NBCA all the way in. It doesn't go into other territories of the tumor. So those are probably the real compartments. But some of them you can diffuse your glue into other, territories also in the tumor. What do you feel about this?
Yeah, actually this technique has limitation, but some tumor compartments have dual stain from both ICA system and ECA system.
Okay.
So in that case, you have to be more careful about the peritumoral anastomosis.
Yeah, I have penetrated from the MMA through the tumor itself into the meningohypophyseal trunk and to the ICA with my glue. So sometimes it crosses the border. Well,
yeah,
anyway, probably
just
sometimes it's only
showing,
distribution. Yeah.
Pre-embolization.
Okay, thank you. Thank you.
Yeah.
Yeah, thank you for the case.
Excellent. Any other questions from the audience? Okay. Dodi, I think we're close to 10. So if you don't mind, maybe we can show your case next time.
Absolutely. Also because I cannot stay here, I'm needed somewhere else. So thank you very much, but it's better like that. It's not really a case, but it's a point that I wanted to make. And so it's better to have a little bit more time for that. Thank you very much, Ethan.
Excellent. All right. So anybody else, any more comments? Again, thank you, Walid, Luca, and Keisuke for sharing their experiences today with us. And I'll see you in a month.
Looking forward to it. Thanks.
Thank you.
Thank you so much.